Okay, when we talk about sepsis, SIRS, and MODS, it's an interesting topic. We could spend all day talking about this whole phenomenon, but we're just going to hit the highlights. First, you need to know what the terminology is. SIRS is a systemic inflammatory response. That's what that stands for, SIRS, systemic inflammatory response syndrome. Sepsis, we know that sepsis is an inflammatory response syndrome that occurs because of infection. So we can almost say, well, we could say that sepsis is SIRS because of infection. But remember that we can have SIRS without infection. So we can have SIRS without sepsis, but we really can't have sepsis without SIRS. Now, sepsis or SIRS, the end result is if these diseases are allowed to continue on, then eventually the patient will get something called MODS, which is multi-organ dysfunction syndrome, which is our really fancy medical way of saying that they're dying because organs are failing. And so when we talk about the way we diagnose MODS, in order for somebody to have MODS, we have to have death or dysfunction of 2 or more organ systems. So a good example might be we lose the kidneys and the liver, or another good example would be we lose the hematologic system in the form of DIC, and we lose the respiratory system in the form of ARDS, something like that. Okay, when we talk about the microbiologic response, we actually have something called exotoxins. They actually are released along with host immune cells. When those two things are released, they collide, and when they collide, they actually release something called cytokine. That cytokine actually causes a release of a bunch of other chemical mediators. And there are also multiple mediators that are released because of the exotoxin and the immune cells colliding. So some of those other things that you'll hear talked about a lot in the literature, because we're just really starting to understand the significance of those things. You'll hear people talk about things like tumor necrosis factor alpha. You'll hear people talk about interleukin 1 and interleukin 6. These are all things that we know cause this whole cascade, this whole sepsis SIRS cascade to occur. Now, these mediators also release something called endotoxins. And endotoxins are things like prostaglandins, histamine, and nitric oxide. Okay, well, why in the world do I need to know all this biochemistry? Well, because if we understand this, we understand what happens in sepsis, SIRS, or MODS. So again, when we have a systemic inflammatory response, we have all these all these exotoxins that are introduced into the body. These exotoxins are introduced into the body, and the body responds by releasing immune cells. When those immune cells and those exotoxins collide, they release cytokines, and they release all kinds of other mediators like tumor necrosis alpha, interleukin 1, and interleukin 6. These mediators release endotoxins like prostaglandin, histamine, and nitric oxide, and those endotoxins are really what are responsible for the reason that people with sepsis and SIRS respond, act, and die from the things that they do. So, when we talk about the systemic response to whether it's sepsis or SIRS, there's 2 stages to the classic presentation of sepsis or SIRS. There's a warm stage and there's a cold stage. In the warm stage, what has happened is all those endotoxins are running through the body, wreaking havoc. All those endotoxins, all that histamine, all that prostaglandin, all that stuff's running around wreaking havoc. And what does it do that wreaks havoc? Well, the first biggest thing that it does is it causes massive vasodilation. Well, remember that your blood vessels are kind of like my hands. When they're nice and squeezed tightly together, they're not very porous. It'd be really hard to squeeze water out of my hands right now. But as they start to dilate, all of a sudden these blood vessels start to become very holy, if you will, or very perforated. Well, the more they dilate, the more they perforate, the more they perforate, the more stuff is allowed to get out. Well, when all that stuff is released out, like albumin and sodium and all that stuff is released interstitial, well, it sucks water with it, and so we lose lots and lots of fluid into the interstitial space. That, again, occurs in that warm stage because of those endotoxins. The other thing that warm stage is doing because of that massive vasodilation is it's producing a clinical presentation that doesn't look like what you and I think of when we think of shock. When we think of shock, we think of the patient who's hypotensive, tachycardic, altered LOC, urinary output sucks, blah, 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 blah. Pale, cold, diaphoretic. that is not the way that somebody looks when they're in sepsis because of those endotoxins. Instead, what we see is that massive vasodilation causes them to be flush, causes them to be pink, causes them to be warm, and also those endotoxins work directly on the heart. They dramatically increase cardiac output. By dramatically increasing cardiac output, they can overcome that massive vasodilation and still manage to maintain a good level of consciousness, good urinary output, so on and so forth. Now, the other thing that happens during that warm stage is we actually start to coagulate all over the place. We start to blood starts sticking together, and if that coagulation process kind of ramps itself into overdrive, then it's very easy for us to make the jump into DIC. And we have massive increases in our tissue metabolism, but yet there's decreases in tissue oxygenation. And this is the key to understanding why people die from SIRS and sepsis. It's most dramatically caused by the fact that their metabolism shoots through the roof. And while there may be some oxygen that's floating around, it's not enough to go around. So because they're hypermetabolic, they would need a tremendous amount of oxygen, but they can't produce that amount of oxygen, not enough to keep up with the metabolism. So these people get lactic acidosis. When we talk about the cold stage, what eventually happens is all those endotoxins burn off. And when all those endotoxins burn off, then we actually have something called myocardial suppressant factor kick in, and it actually suppresses how well the heart works. And so we see cardiac output go from being way, way high to being way, way low. The other thing is all their nitric oxide is consumed, their systemic vascular resistance falls, and they vasoconstrict down, and then finally, they look like what we think of when we think of shock. The only problem is by the time you're in the cold stage of septic shock, by the time you're pale, cold, diaphoretic, crappy urinary output, crappy LOC, crappy blood pressure, you're at the point where you're not salvageable. So it's vital that we recognize these patients in that warm stage where they're still alert, they're still peeing, they're warm, they're peaked, they're dry, and they're hyperdynamic. Okay, now the criteria for the different diseases. You don't need to waste your time in memorizing all this. This is just here for your information, but it helps to understand the stages, if you will, of sepsis and septic shock and all that good stuff. And so the very first thing that we can diagnose somebody with is SIRS. So in order to say that somebody has SIRS, we have to say that they've got massive tissue insult of some kind, whether it's an infection, trauma, whatever, and they meet two or more of these criteria. So the criteria are their temperature is either high or low, i.e. above 38 or below 36, their heart rate is greater than 90, they've got respiratory alkalosis, or their respiratory rate's greater than 20, or they've got a increase in their white count or a decrease in their white count, or they've got 10% bands. If they meet any two of those criteria, then we say that they've got SIRS. Now, in order to say that somebody has sepsis, they have to have SIRS, plus they have to have a source of infection and at least one of the following. They have to have an alteration of their metal status, they have to be hypoxic, they have to have an elevated lactate, or they have to be oliguric. Once we've got one of those plus SIRS, and we have a probable source of infection, then we could say the patient is septic. In order to say that somebody is in severe sepsis, what we have to say is that they've moved on to the point where they have organ dysfunction, hypoperfusion, or hypovolemia. They have to have one of those three things. And finally, in order to say somebody is in septic shock, what we have to demonstrate is that the patient is in severe sepsis that is refractory to fluid. So in other words, they're hypovolemic, we fluid resuscitate them, and they're still hypovolemic. So that's how we make the diagnosis of septic shock. Now when we talk about the treatment for management of sepsis and SIRS is actually very clearly defined. There's a goal-based therapy matrix that's out there that pretty much everybody has endorsed. It's a consensus document that talks about the way that we manage sepsis, SIRS, and MODS and all this other good stuff. And the very first thing, obviously, that we need to do for these patients is obviously protect their ABCs, make sure that their airway's protected, make sure that their breathing is adequate, make sure their circulation is adequate. We want to give them lots and lots of oxygen to ensure that they're getting adequate oxygen delivery to as much tissue as possible. And we also need to start immediate resuscitation if the patient, immediate fluid resuscitation if the patient's hypotensive, or if the patient has a serum lactate that's greater than 4, which is a key part of management of sepsis. Very early on, as soon as you suspect your patient has sepsis, one of the things that we want is a serum lactate. If the serum lactate is greater than 4, that proves lactic acidosis. That patient needs to be treated aggressively. Now, if the patient has honest-to-God sepsis or SIRS, almost always those patients are going to end up in respiratory failure. They're going to need intubation. The big problem is that these patients, as they go into multi-organ dysfunction syndrome, one of the very first things that usually goes is the lungs. And the way the lungs go is in the form of ARDS. So when we talk about management of mechanical ventilation in sepsis patients, the consensus is we typically want to keep the tidal volume low, usually less than 6 cc's per kilo. If the patient's hypercapnic, that's okay. We'll tolerate that. We certainly want to keep the patient's peak inspiratory pressure and their peak plateau pressure less than 30. Ideally, we would like to look at the peak plat. That's the more valuable number. But if we don't have that, we can at least look at the PIPs and try to keep the PIPs below 30. We want to keep we want to provide PEEP if the patient's having problems oxygenating. And the other thing that's really important that we know decreases the chances of ventilator-acquired pneumonia is anybody who's intubated, mechanically ventilated, should be sitting up. Their head of their bed needs to be elevated. Okay, when we talk about goal-directed therapy, once we've established the airway and the breathing, then we need to focus on the circulation. And the circulation, basically what we're going to use, there's 4 kinds of things that we look at. The very first thing we look at is we stick a central line in these patients and we measure their CVP. Ideally, that's the ideal management. If their CVP is at least 8 to 12, cool. If it's less than 8 to 12, then the patient needs to be fluid resuscitated until it's at least 8 to 12. Now, if the patient's mechanically ventilated, we shoot our numbers up a little bit higher. We say that we want their CVP to be at least 12 to 15. If we don't have CVP, if we have not had a chance to put in a central line yet, or we don't have the ability to put in a central line immediately, then we look at the MAP, and again, we want the MAP to be at least 65. If the MAP is less than 65, the patient needs to be fluid resuscitated until the MAP is at least 65. Also, we want to watch the urine output very closely, and if the patient's urine output is less than half cc per kilo per hour, then we need to be giving that patient lots and lots of fluid. So again, we're looking for a urinary output target of at least 1/2 cc per kilo per hour. Now, if urine output sucks, the CVP sucks, or the MAP sucks, then the question becomes, is it the heart or is it the vascular space that's causing our problems? If it's the vascular space, we're going to treat that with fluids. If it's the heart, we're obviously going to treat that with, if it's the vascular space, we're going to treat it first with fluids. If it's the heart or the vascular space, the next thing we're going to do is we're also going to treat it with pressors. When we talk about our pressors, the drugs of choice are dopamine and norepinephrine. Those are our first 2-line choice drugs for sepsis, SIRS, and MODS. If that doesn't work, then we can also try infusions of things like epinephrine or vasopressin. Now, when we talk about sepsis, one thing you need to know about sepsis is that a significant number of these patients are actually adrenally suppressed. If they're adrenally suppressed, in addition to the fluids and the pressors, they're still usually going to still be hypotensive. And if they're adrenally suppressed, the way we treat that is we give them steroids. So when we're talking about hemodynamic management of sepsis, basically what it boils down to is first we treat it with fluids. If they're still hemodynamically compromised, we put them on pressors. And if they're still hemodynamically compromised, then we think that they're adrenal suppressed. That's why the pressors aren't working. So we put them on steroids. So you can almost think of it as a boom, boom, boom response. Boom, first fluids, lots and lots of them. If that doesn't work, then the next thing we do is we go to pressors. Finally, if that doesn't work, then we go to steroids. When we talk about going back to fluids for just a second, when we talk about which fluids to use, there's been lots of literature that's looked at crystalloids. There's been lots of literature that's looked at colloids, and there has not been a demonstrated advantage of one over the other. Okay, one other thing that we want to do as soon as we get that central line in is we also want to draw blood on it and send it off for a blood gas to get an SCVO2. The SCVO2, we would like to see that it's above 70. If it's not greater than 70, then that tells us that the patient is consuming too much oxygen and we need to improve their oxygen delivery. And we're going to do that one of two ways. We're either going to give them blood or we're going to put them on dobutamine. So if their hematocrit is less than usually about 8 or 10 or so, then our choice will be first to try and give them blood. If their hematocrit is within a relatively normal level, then what we're going to do right off the bat is we're going to put them on dobutamine in addition to all the things that we've done thus far. Okay, some other things that we want to do. We want to get blood cultures, and we want to get cultures from every other fluid that we possibly can if we don't know the source of infection. Remember that the more cultures you get, the more likely you are to get accurate results. So we usually say that we want at least 2 to 3 sets of blood cultures, at least 2 to 3 sets of urine cultures, and then we'd also like to get like sputum cultures and all that other good stuff if we can. There's a tremendous amount of literature that's demonstrated that if you can keep the blood glucose less than 150, you dramatically increase the patient's chance of surviving. So we want to be very tight with the glucose. We want to make sure that their serum glucose stays less than 150. Remember that it's a normal stress response to dump lots of glucose, so if these patients have a high glucose, then we need to lower it with insulin. If the patient's glucose is low, though, we need to give them glucose. So we'd like to keep it in a relatively tight range, like somewhere around, say, like 70 to 150. Other things that we want to do, if the patient's got an Apache score that's greater than 24, then we need to consider giving the patient Zygris. Zygris, remember, is activated protein C, and what it does is it prohibits the blood from clotting in all the microcapillaries and causing all those micro tissue bed occlusions that we see in sepsis and SIRS. If the patient's got metabolic acidosis and it's because of lactic acidosis, then there is no point in giving the patient bicarb. Bicarb is not going to fix them. Lactic acidosis is because of a lack of oxygen, not because of a lack of bicarb. So there's no point in giving them bicarb if they're in a metabolic acidosis, and specifically we know that it's a lactic acidosis. And other general things that we want to do for these patients in the ICU, DVT prophylaxis is really, really important. So we want to start them on some kind of heparin product. And then the other thing we want to do if they're intubated especially is we want to start them on a stress ulcer prophylaxis as well. Okay, last but not least, just a review of some quick signs that we may be asked questions about on exams. When we talk about Brudzinski sign, remember Brudzinski sign is when you push down on somebody's head who has meningitis, and that causes meningeal irritation of their neck. Typically, they'll complain of pain, and they'll bring their legs up towards their body. When we talk about Koenig sign is when we lift the legs up of somebody who's got meningitis. That will cause them pain and discomfort, and it will typically cause them to pull their head in towards their body. So you can almost think of Brudzinski's and Koenig's as being kind of like two extremes of the same sign. Again, with Brudzinski's, we push up on the head, the legs come up. With the Koenig's, we pull up on the legs, and the head comes up. Now, when we talk about Cullen sign, remember Cullen sign we said went with pancreatitis. The picture right above me is a beautiful example of Cullen sign. That's that periumbilical bruising that we see with hemorrhagic pancreatitis. Also with pancreatitis, we may see something called Gray-Turner sign. Gray-Turner sign is where we have bruising in the flank and in the groin. And we may see continuous bruising, or we may see independent bruising in both places. When we talk about Kerr sign, remember we said Kerr sign again was that left shoulder pain that comes with a splenic injury. When we talk about Murphy sign is the way that we diagnose gallbladder problems. And remember the way we do that is we find the bottom quarter of the rib cage, we push in and we ask the patient to take a deep breath. If they can't do that because that hurts, that's a positive Murphy sign, and that tells us that they've got biliary stones most likely, or some kind of gallbladder inflammation. And finally, the last sign that you may be asked about on an exam is Levine sign. Levine sign is when the patient holds a closed fist over their chest, and we know that that's classic for patients with myocardial type pain. Well, thank you very much for spending your time with me today. Again, my name is Anthony Baca. If you have any questions, feel free to email me. My email address is abaca@camanagement.org. That's abaca@camanagement.org. Or you can visit us on our website, which is www.camanagement.org. That's www.camanagement.org. Thanks again for spending your time with us, and I hope that you have a phenomenal day.